A very good evening to everyone. It's a pleasure to introduce our speaker for today, Professor Chi Lu, who is a principal investigator from the Centre of Eye Research Australia in Melbourne. Now, Professor Chi brings over 20 years of experience in vision research, including pioneering research in vision restoration strategies for degenerative retinal diseases. Now, Chi impressively has more than 170 publications to date and has numerous international recognitions, such as election to the prestigious Macular Society, and is also named as an Old Avo Fellow. Now, without further ado, please join me in welcoming Professor Chi.
Okay, thanks, Wendy. Thanks for the introduction, and thanks for the invitation to speak at the webinar tonight. Yeah, so just before I start, I just like to acknowledge the contributions of all my colleagues and collaborators from different institutions in Melbourne. So what I'm going to talk to you about tonight is just a effort from a large team of a large number of people. And I also acknowledge the funding sources from various agencies in Australia and overseas. So yeah, so let's talk about electroceutical applications in retinal diseases. And so I think you all know that electroceuticals is a medical device that used to interact with our biological system, and that can be used to diagnose, monitor, and treatment of a broad spectrum of disease. And in terms of treatment, it's mainly used electrical stimulation to modulate or control the biological process, and by doing that, we can restore or enhance physiological function. So a good example for this is that, as we all know, or well known, that a pacemaker and cochlear implant, but the technology has been expanded to a much wider condition, many more conditions, and vision of the eyes included. So that is the focus of the talk tonight. So tonight I'm going to talk about using electroceuticals for restoring vision, for neuroprotection, and for enhancement of gene therapy in the context that it is for treatment of inherited retinal diseases. So let's start with vision restoration. So we can, to apply electroceutical for vision restoration, we need to have this device tissue interface, and for this, there's a number of sites within the visual pathway that we can have the device implanted and provide this interface. So we could have the device implanted at the visual cortex, or at lateral genetic nucleus, optic nerve, or the retina. But the focus of the talk tonight is mainly on retinal implant. As we know that in retinitis pigmentosa, the outer retina lost totally, and even despite of the total loss of the outer retina, the inner retina is relatively preserved. Even after a long time, the photoreceptor is lost. So that gives us an opportunity that if we can activate these inner retinal cells, we will be able to restore the vision, or at least some level of vision. And so to do this, really, this is the concept of retinal prosthesis. So the concept of retinal prosthesis is that it has two main units. It's called an external unit and the internal unit. The external unit consists of a camera, a vision processor, and the stimulator. And the internal unit is that we got the electroarray, which is used to stimulate the retinal cells. So how this works is that the camera will capture the image of the visual scene, and then the vision processor will process that image and determine the stimulation or the stimulation level that is required um, to represent that image. And then it sends that to the stimulator, and the stimulator sends the electrical current to the retina to stimulate that part of the retina. Now, if we can stimulate the retina with multiple electrodes, which form the pattern, and that pattern of visual perception can help us to determine the form of vision. And in this in the example, you will see that a letter E was formed with a pattern of multiple electrodes. There's a number of different places in the retina that you can place this electroarray. So in the past, group has placed it in the AB retinal surface, or you can place it in the subretinal space. In our case, we choose to have the array implanted in the suprachoroidal space. And the reason for doing that is that we find that the suprachoroidal space will provide a much stable position, and that stability help to increase the longevity of the device, and also the avoiding damaging the retina. So in 2012, we started a prototype trial where we have a 24-channel prototype device. And so this device was implanted in three RP patients with bare perception of light. So after implantation, patient will undergo 3 months of recovery and device fitting. And after that, they will undergo functional vision testing, which include light detection, object detection, and mobility. So in light detection, we presented a segment of light on the screen, which could be either in a left, right, up, or down, and the patient will need to tell us whether which direction the light is. And as you can see here, that when they use the device or when the device turn on, the correction is much higher than the device off. So they obviously it's shown that they can see better with the device of detecting the direction of the light when using the device. We also attempt to measure acuity using the prototype C, and you can see here when they use the device on, that we managed to get some level of vision. We also look at activity of daily living, where they need to identify symbol object in the house, and you can see that again they can perform better with the device on compared to the device off. So vision processing take a very important part in retinal prosthesis. As you can see here, we're testing different stimulation mode. One is just on and off, meaning that when there is an object, there is a stimulation. But we're also using what is it called, intensity cue. So we use that intensity as a cue for how far the object is. And you can see that with that intensity cue, and the patient needs to navigate around the obstacle course, they can do it much better in terms of, to see where the object, but also how far the object from them. And that has increased their performance. Now, of course, this 24-channel device has a number of limitations, but the main limitation is that because it has a percutaneous plug, and therefore we can only test that in a lab environment. Patient can use that outside or at home, and also it has a limited field of view. And so to improve that, we have developed a second generation device which has the exact blueprint of the first generation, but it's contained more number of electrodes, which in turn increase the field of view and also allow a better stimulation. So this 44 channel second generation device is powered by two cochlear stimulator, and we need this two cochlear stimulator because each cochlear stimulator only had about 21, 22 channel, and therefore we need to power the 44 channel generation device. So in 2018, we initiated a second trial with this device, and we have recruited 4 patients for this trial. And similar to the previous trial, so patients go under the implantation and then followed by a period 3 months of recovery and device fitting. Follow that, they go for 4 months of visual perception training and continue with 3 monthly assessment over 2 years. So this is the clinical characteristic of the patient for the second generation trial. So again, they all have very minimum light or bare light perception vision. And one patient has the electrode implanted in the left eye, and the remaining 3 of the patient have the device implanted in the right eye. So this is what it looks like in the back of the eye after the implantation. As you can see there, the position of the electrode just underneath, just underneath the fovea and just close to about 1 disc away from the optic disc. So this is after training and fitting. The patients was testing the light detection, or in this case, the square localization, where they need to point where the location of the square is. And we measured the distance between the center of the square to the finger where they point the square and work out what is that pointing errors. And you can see that on the graph on the right that the pointing errors is much less when they use the device compared to when the device is off. In terms of detecting the direction of moving bars, so the bars can either move left, right, up and down, and you can see with the device on, the number of correct detecting the direction of the moving bar is much better than the device off. In terms of grading acuity, so we managed to estimate the grading acuity in one patient, and so that is one patient consistently passing the criterion of 75% at 0.033 cycle per degree. The other 2 patients did not manage to pass that criterion level. In terms of table task, where the patient need to identify where the object and then name the object. Again, as you can see, with the device on, they can correctly identify the object much better with the device on compared to the device off. We also test their mobility by setting up the obstacle course, and they need to navigate the course and avoid the obstacle. As you can see there here on the chart, that with the device on, they can detect the object better, and in terms of the number contact is less with the device on. Here, where they need to identify the doorway, so we put a black cardboard on the wall to represent the door, and so the patient needs to identify where that is and walk toward the door and pointing it. And you can see the dot on the right that with the device on, they are detecting and successful touching the door is much better compared to the device off. We also test to see how they can see if there is an empty chair or a face in the environment. And here's, as you can see, again, with the device and with the algorithm, with face detection or chair detection algorithm, they can see much better with the device on compared to the device off. So the normal algorithm, using the normal algorithm, they have trouble seeing white object compared to black object. And so we have developed a new algorithm called multimodal vision processing, and that has significantly enhanced the performance identifying white object. As you can see here, the M&M model has improved the performance of detecting white objects significantly. So they can see better, they can identify the object better, and they have significantly reduced the contact of the object. In terms of patient-reported outcome, as the study progressed, they feel that they can orientate better. So the device help them help their orientation. It feel that the device help with their activity of daily living and interact with others, but they didn't quite feel that the device significantly help with their mobility. And this is mainly because that when using the device, they feel that their motility is much slower compared to their normal using guide dog or a cane, because they have to process that information, and that has slowed them down. So they didn't feel that as useful. In terms of adverse events of the device, so there's no serious adverse event, but there is quite a number of adverse events, and those mainly headache and sensitive to light and ocular discomfort. And this is mainly due to because of there's spent a lot of time in the lab and testing, and so that associated with such a adverse event. We also have an ability to look at the long-term stability and safety of the implant. So up to 2023, patients from the first prototype trial would have reached almost 10 years after the initial implant, and the patient from the second trial reached about 4 years after implant. And so here's looking at the retinal thickness over the study period. So the 44 channel is up to around just about 4 years, and the 44 channel device reached almost 10 years. And you can see that there is minimal change in the retinal thickness, which sort of suggesting that the device doesn't cause any harm in the retina. In terms of the stability, so here we're look at if it's the movement of the device. So so this is a measure of the tip of the device to relative to the retina, and you can see there are 3 after the 4 patient. They're virtually very minimal movement of the device throughout the course of the study, except for in patient 1, there is some movement of the device initially. In terms of the functionality of the device, so there is one or 2 patients lost one of the electrodes in the 44 channel study, and there's one patient lost 2 electrodes, and one of the patients that all the electrode working throughout the study. So there is a minimal loss of electrodes of this device, which sort of again sort of indicate the stability of the electrode is important for the longevity of the device. So in summary, the suprachoroidal procedures seem to be safe and straightforward with the surgical approach. The device is fairly stable in position in the suprachoroidal space, and that in turn enhance the longevity of the device. And we find that the patient consistently seeing the phosphine, which is it's important because that's not only indicate that the retina is remain unaffected and the device is remain functional. And we has demonstrated that there is an functional improvement using the device. So the next application is using the suprachoroidal stimulation for neuroprotection. So we know that inherited diseases is now the major cause of blindness in working adults. And because there are almost now over 300 genes that's associated with the disease, so finding a cure to treat the disease is quite a challenge. So we have a large number of patients without available treatment for them. And so any treatment that could prevent or slow down the progression to extend that, the vision light of the patient would be very valuable to the patient. So while they're waiting for the treatment to become available, if we can slow down and give them, extend their visual life, then that will be that will help them to continue with the workforce and will be important for their quality of life. So back in 2004, this group, so in this study is part of the retinal prosthesis or bionic eye study, where they implant an electrode in the back of the retina, and it's supposed to test whether this electrode could generate phosphine as a part of vision restoration study. And by doing that, they noticed that patient visual function improved over time. And so you can see here that in the stimulated eye, their visual acuity slightly improved and consistently improves over time. And their visual field also improves over time. And so it has been postulated that this improvement might be associated with neuroprotection. And follow on that, quite a number of clinical study, showing a similar finding that if you provide a chronic low level of electrical stimulation to the retina, it slows down the progression of the disease. And so we have quite good evidence, clinical evidence, that chronic stimulation does help reduce the retinal degeneration, the rate of retinal degeneration. And data also show that this is likely to do with the upregulation or productions of neurotrophic factor. So the current understanding of the mechanism of action for this neuroprotection is that low level of chronic retinal stimulation will activate the intrinsic survival system in the retina, which sort of activate the cascade of event. It also improves in chorioretinal blood flow, and that will then lead to protect the neurons from dying and therefore preserving vision. The challenge we have at the moment is that the patient either have to put the electrode on the cornea surface or around the eye, and that could be challenging and could be the feasibility could be questioned if you have to do that routinely over many years. And so we're trying to find a solution for that. Now, we know that the suprachoroidal electrode array is fairly stable and safe. So we want to see whether if we design a minimally invasive device, that whether we can use that as a neuroprotective stimulation. Now, why the suprachoroidal is more attractive than the other sort of device or other implantation site? And you can see here that the suprachoroidal location is much simple and safe in terms of the surgical approach. It has much more stable position. It has a lower risk of retinal damage, and it doesn't affect natural vision. And we'll be able to replace or remove if necessary later on. So it's got ticks all the boxes for that. So to test and prove that the suprachoroidal device can give neuroprotection as we stimulate from the transcorneal approach, we have developed this miniature stimulation array where we can implant that in the rat eye, and we have the connector that we turn to the back of the head, and that's connected to the pedestal, and that sort of this model give us that we will be able to stimulate the retina while the animal is awake, and to see if that chronic stimulation help protect the neural degeneration, the retinal degeneration. So the image here you can see that in the color fundus photo you can see that the electrode that's implanted in the suprachoroidal space, and that's confirmed with the OCT and also confirmed with the histology down at the bottom left. So in this study, we used the Pro 23 Hayes rat model. So this model is the rhodopsin model of retinal degeneration, which has the autosomal. It mimic the autosomal optic retinal retinitis pigmentosa in patient, and you can see that by week 7 of age, this model has lost about 50% of their outer nuclear layer, and then in terms of retinal function, it lost another 50% of the retinal function if you follow up for another 3 or 4 weeks. So here is the EIG data from that cohort. So we have an example of EIG response on the left and the group data on the right. So you can see there in the control group, so 4 weeks after the baseline, the EIG reduced around like half. But if the eye is treated with electrical stimulation, there is a preservation of the retinal function associated with the treatment. So, and that also, we can also find that associated with a preservation of the outer retinal thickness in this cohort. So that result sort of encouraging, and then we proceed further to develop a clinical grade device that hopefully we can bring that to patients. So this is the comparison on the picture on the left. There is comparison of the bionic eye array versus the minimally invasive retinal protective neuroprotective array. And then we have just recently completed that safety study, which showed that the neuroprotective array is quite safe with a minimal tissue response to the array, as you can see there. Now, because we want to eventually we hope that this device can be implanted in the patient and hope that it will slow down the retinal degeneration. So monitoring retinal function is a key. And so we want to see whether we can use the electrode from the array to measure ERG and use that ERG to monitor the change in or the rate of retinal degeneration. So you can see here the conventional ERG when it's recorded with corneal electrode compared to the mirror electrode, where the electrode from the suprachoroidal array, the waveform look remarkably similar. And in terms of the reproducibility or the variability of the recording, so if you look at the data on the right side, so this showing the cumulative distribution of all the measurement as of the x-axis, and the y-axis is the percentage of change from baseline. So the mirror electrode, which is the data in red, as you can see there, about 50% of the measurement or half of the measurement is within about 10% of the variability. So you can see that compared to the corneal electrode, where so many of the electrodes vary quite a lot from individual measurement. So it's sort of promising here to see that the mirror electrodes sort of help improving these variability of the ERG measurement, and hopefully that will translate to a more sensitive assessment of retinal the rate of retinal degeneration. So yes, so summary for neuroprotection. So the suprachoroidal neuroprotective device appear to be safe, and chronic stimulation appear to reduce the rate of retinal degeneration. And of course, using the electrode within the array, we can use that for ERG recording and monitor retinal function. So moving on, so the third part of the talk, which is using the electrical stimulation from the suprachoroidal space to enhance the gene therapy. So we know there is an increasing gene therapy for inherited retinal disease, and the two main approach for gene delivery is either subretinal or intravitreal delivery. So with the subretinal delivery, you will obviously have a better efficacy, but the procedure is more complicated and it's running a higher risk. The intravitreal, it's quicker, it's easier, a lower risk, but lack of the efficacy is low. And so the question is, can we use electrical stimulation to improve the intravitreal delivery of gene therapy? So in this study, we deliver intravitreal delivery of AAV2 or AAV7MA, and we have 3 different group of mice, whether one with no AAV injection and group with AAV, and in the group with AAV injection, whether one didn't have the electrical stimulation and one received electrical stimulation. And we want to see whether electrical stimulation increased the GFP expression in the retina. And you can see that the data down the bottom left, that's compare, so AAV2, the extra stimulation, there's an increased level of GFP expression compared to no stimulation, and same as the AAV7MA. And so that's encouraging. That sort of tell us that yes, you can enhance, you can improve the efficacies of gene therapy with electrical stimulation. We then ask whether if we can do intravitreal delivery of AAV and intravitreal stimulation, can we get a more focus, or we can target certain area of expression, and we quite not have the evidence for this yet, and so this will be updated in the future when we have a further evidence on this. And then the last sort of portion of the talk is the hybrid stimulation, where we can combine electrical and optical stimulation in the retina. So we know electrical, so this is in related to, again, back to the vision restoration. So using a bionic eye technology or retinal prosthesis, we know that the resolution of vision restoration is still very low. With optogenetic, there is a potentially can provide much better resolution for in vision restoration. But the challenge with optogenetic is that at the moment we still require a large number of energy, so I mean bright light, to stimulate neurons. Hopefully it will get better in time, but at the moment it will still require a large amount of energy to activate a cell. So in one hand, optogenetic gives us a better resolution, but it requires more energy level. In retinal prosthesis, it gives you a low resolution, but so we think asking whether we can combine electrical versus optogenetic together, that will enhance the energy requirement for and also the resolution. And so this is what we call a hybrid stimulation. And you can see on the top left there, light stimulation as a designated as ours, or electrical stimulation alone, that generate a very high threshold, whether when you combine both together, you can measure lower threshold. So that a combined hybrid stimulation gives you a better threshold. So not only that, when you combine electrical and optogenetic together, or hybrid stimulation, it also improves the temporal resolution or temporal kinetic of the cells. So it gives both better threshold and better kinetics, temporal resolution, and so hopefully that will eventually translate into a better resolution of vision as well as the safety. And so we just start embarking this recently, so hopefully we will have more results to update in the future. So the way that we see how's electroceutical application for inherent retinal disease is that when in the early stages, potentially, if there is no treatment, potentially we could implant a neuroprotection device, and that will help prolong the visual life of the patient to a certain time. And then when the vision deteriorated or progressed to advanced stage, and if at that time there's a gene therapy or optogenetic therapy or cellular programming available for vision restoration, so they could receive that. And if a gene therapy potentially that device, by stimulating that device, might help to improve the efficacies of those treatments. Or if there is no treatment available and we need to, let's say the bionic eye device is become a little more advanced and have a little bit better resolution, we could potentially remove that neuroprotection device and replace it with the bionic device for vision restoration. And so with that, I think I will stop here and happy to take any question. Thank you.
Okay, great. So maybe I'll just check whether any of the panelists have questions for Prof. Chi.
Yes, I have many questions actually. That was a great talk.
Yeah.
And I don't know how to start off. Maybe I start off with the retinal implant. First and foremost, I would like to know, just like all implants, especially the glaucoma implants and everything, there's a tendency of forming fibrosis, which I don't see it in your case.
Mm-hmm.
What kind of coating do you use it? Did you use one? Yeah.
Yeah, so there is no coating whatsoever. So the device was made of a silicon and platinum. So the silicon substrate with the platinum electrodes. And I think so we do see a little bit of fibrosis, but not at the extent that we see. And the fibrosis, the more the fibrosis that we see usually related to the amount of stimulation that we put in the retina rather than the device itself. And same as a cochlear implant, we do see some level of fibrosis around the device. And in a way, it sort of helps keep the electrode in place. So rather than having a negative impact. So a little bit of fibrosis actually help to keep the device in place in a position. But it doesn't actually cause, let's say, increase the threshold in the retina as such.
Thank you. I just squeeze in one more question before letting Prof Graham to ask.
Yeah.
I think everyone is fascinated by the electrical retinal, is it retinal or choroidal? Retinal stimulation.
Yeah.
Yeah. Perhaps one of the most important question is, what do you think is the mechanism that promotes this protection?
Oh, protection. Yeah, we do think it's well, from the data that are available, so the current understanding is that when you stimulate the retina at a very low level, it actually activate this survival system, which in turn upregulate all the good factors and deregulates all the bad factors. But it also improved the retinal choroidal blood flow. So we think a combination of all that sort of that help slow down the disease progression. But that's what we sort of understanding at the moment. But hopefully we will have more data to have a better, deeper understanding of the mechanism.
Prof Graham's turn, I think.
Yeah, a couple of things, Chi. Nice talk. You showed that with the implant in place in the RP rats, that
Yeah.
you were able to preserve the ERG.
Yeah.
For how long did that last? Did you do longitudinal
Yeah.
data?
Yeah.
Did it eventually start to die off?
Sure. So that study is only go for 4 weeks. So and we know from if we not do anything, the EIG will reduce in half. But if we give a stimulation, it's fairly preserved. But I don't know how long it's preserved because we haven't done any study further than 4 weeks.
That would seem to me to be quite important.
Yes, yes, but we know the reason that we haven't looked at any further than 4 weeks because there are so much clinical evidence out there showing that chronic stimulation that preserve or slow down the progression. So we don't need to do an animal to prove that anymore. We just want to show that it's actually the suprachoroidal actually do the same thing as if you stimulate it in the cornea, corneal stimulation. But because there is so much clinical data out there available, which already show that, you know, chronic stimulation do slow down the progression. So we didn't feel that we need to repeat that in an animal model.
Is it not possible that having a direct contact or a much closer contact to the retina might increase CNTF production and therefore be more efficient?
Well, we know that it doesn't matter whether you the effect is global, it's not the local. So it doesn't matter whether we stimulate it on the cornea side or the orbital side or on the cerebral. So we don't think it's a local effect. So we don't think that we need to be close to the retina. Yeah, so I don't because you get the same effect if you stimulate it at the cornea. So we don't think it's just the site of the stimulation actually make it much different.
Great, thank you. Can I ask another question, or is there a huge queue of people?
Please go ahead, Prof.
What are your plans for the future in terms of the retinal implant? Because we know that the Argos implant has died a death, so to speak, because unmet expectations and some failure. And you've only got 7 patients. Do you intend to carry on with that? Or are you looking towards perhaps cortical, feeding the signal into the cortex?
Yeah, so we definitely don't want to go to the cortex because it's carry more risk. The failure of the implant, there's so many factors, but I think it depends on, currently it depends on whether we can improve the resolution of the vision result of the bionic eye device. So that has a limited, yes, so that has a limited, if you're talking about a commercial device, that will have a big limitation. But if you were thinking about a neuroprotection, then it's open to have a much wider market. So if we use it as a neuroprotection, then it's not only, so if it's work in the RP, potentially it could expand to, say, glaucoma population when we can use it for neuroprotection in glaucoma. So I think neuroprotection must have a broader or a wider application as opposed to a bionic eye device used for vision restoration. But again, it depends on whether we can go to the next step and giving a better resolution. If the resolution is not great, then I don't think the bionic eye will go much further.
Okay, thank you.
Thanks, Chi Lu. Sini here. If I could just ask a question. Just
Yeah.
curious about the last project that you presented on using stimulation to enhance gene therapy. Just trying to understand what is the mechanism behind it and where do you think would be the potential in the future of using a combination of a biological approach versus electrical approach. If you could comment on that. Thank you.
Sure. We're not quite sure the mechanism, but I think it works probably the same way as electrophoresis. So it might open, well, one of the sort of potential mechanism is that it might help, because of the current flow, it might help drive the vector pass through the retina easier. But we don't quite sure what is the exact mechanisms of that, but that is one of the potential mechanisms. And then your second question is about whether we can combine the two. Potentially, yes, but I understand that maybe, future, there's a lot of people trying to improve, gene delivery and help to improve the efficacies of gene therapy. But if we can deliver the gene with a little bit less concentration to avoid inflammation and immune response, by combining that with electrical stimulation, then that could be an avenue for it.
Thanks so much. I think there's a follow-on question from Clement. He's asking if the optic nerve itself is stimulated or was it through the RGCs?
It would be through the retina, through the RGC. Yeah.
Thank you.
We have another question from the audience from Najia. So she wanted to understand a bit more about the challenges that have been faced with electrode and retinal tissue interface stability to maintain the constant signaling.
Okay. Thanks for the question. So the reason that we choose the suprachoroidal approach is exactly for that, because the electrode is sandwiched between the sclera and the choroid, and so that helps protecting the device and also the stability of the device. As we know, the eye is moving a lot, and so any movement of the device not only cause damage to the device, but also damage to the retina. So the fact that the position of where the electrodes sit, it sort of helped to improve the electrode sort of functionality. So that's different if you were putting the electrode array on the surface of the retina in the AB retinal approach, or the subretinal space in the subretinal approach. That stability is not as good as in the suprachoroidal space.
So I have a question, just to follow on that, because I think previously you've also shown some data where amongst the array, 1 or 2 electrodes might stop to work over time. Is that something that actually translates into a thing that the patient notices, or it's negligible to them?
No, that's the patient won't notice that. But because we do check them regularly in terms of the connectivity, and we identify that. And usually that electrode array faulty is to do with the connector rather than the array within the eye itself. And so there is an opportunity or within the lead wire, so the lead that connect from the array in the eye to the stimulator. So we could make improvement on that in terms of putting more support sections of that particular weakness. So when we were doing safety and chronic study, we have identified several areas that we need to have a little bit more supportive to protect the lead wire and the device, and that has helped to reduce that number of device faulty, the electrode faulty.
Just curious, because some patients may need neuroimaging, MRIs, etc. Is this something that would affect the ability to undergo additional investigations?
So it's the same as a cochlear implant. So yes, so certain imaging we were able to do. I can't remember. There is one that we want to do, but certain imaging. So we have one patient with epilepsy and need device, and that was okay. That was fine because it is small and it's very similar to the compound.
Okay, good to know. So can I just clarify, because I think for the neuroprotective stimulation, there were some images of patients. Thus far, has there been any experiences reported from the patient's perspective on how they find it?
We haven't run any clinical study in patient yet, but in other clinical study that have done in patient, so I don't think there's any patient-reported outcome as a part of their outcome measures, but in terms of visual field and vision testing, they were reported they either improve or remain at that level over time.
Okay, thank you. So just going to check the question box. Oh yeah, I guess that question is similar to and has already been removed. Okay,
Yeah.
great. Okay.
Can I ask another question, please?
Yeah, great.
If I was slightly surprised when you said that the patients had their mobility reduced when they were using the device.
Yes.
Does that mean that they preferred not to use it when they were out on the streets?
Yes. So they reduced. They reported that the device doesn't help with their mobility because there's too much information that they need to process to use it for navigation, and so they much prefer to use the cane or a guide dog because then they don't have to think about anything. But the issue that the problem that often that they tell us is that using the cane that they often bump into hanging obstacles. So because that doesn't help. So yeah, so I think when they're using the device, I think that and maybe a combination of cane will help in terms of the mobility, because the cane can help them move faster, but then the device might help them to detect certain hanging obstacle that they might bump into.
Did you put the implant inferiorly in the retina to maximize the chance of picking up the superior images?
No, we're trying to put it as horizontal balance between the superior and inferior, but we haven't trying to place it more inferior retina so then they can see a little bit more in the superior visual field.
Okay. Thank you very much.
Okay. So just to be mindful of the time, I think we're approaching 7:30. So thank you, Prof Chi, for an excellent talk today. And thank you to all our panelists, as well as attendees who have joined us for this evening.
Well, thank you. Thank you, Wendy. And yes, thanks for the invitation to talk today.